Okay, so Pseudomonas is one organism that I feel that we need to know very well. They ask questions on Pseudomonas a lot. So um, it's an aerobic motile organism because it has a flagella. So it can move with the flagella. That's why it's motile. It is catalase positive. It is oxidase positive, but it's non-lactose fermenting. So we're able to remember that it's oxidase positive alongside with Poquidopherial cepacia, and it's a non-lactose fermenter. The habitat where you typically find Pseudomonas is water. So people that get in contact with water bodies can develop some Pseudomonas infection, and we are going to talk about some of them. Its virulence is increased in acidic environment, and it has grape-like odor. So that's one thing about it. It has grape-like odor, and most of the time, infection from Pseudomonas brings about production of greenish discharge. Greenish discharge. The acronym to understand the infection that Pseudomonas causes is also from the name Pseudomonas. Pseudomonas. So Pseudomonas. So P for pneumonia, the S for the sepsis, the E for ecthyma granulosa. So ecthyma granulosa is just granulosa. It's more like a skin lesion. So okay, we don't have a picture for it here. We have it in the previous. Okay, that's this is it just here. This image B is what we have. So this ecthyma granulation. So you can see that it's like a gangrene of that skin over the chest. So the way it's evolved is that it starts with hemorrhagic vesicle that ruptures and they form necrotic um, areas of necrosis following that rupture. So those areas of necrosis are now surrounded by erythematous area. So hemorrhagic vesicle that ruptures leading to necrosis of the tissues following the rupture, and those necrotic areas are surrounded by erythematous border. So that's your ecthyma granulation. It's characteristic of Pseudomonas, and it typically occurs following bacteremia. So once Pseudomonas has caused sepsis, there's bacteremia, it can lead to this ecthyma granulation in any part of the body. And it typically occurs in people that are immunosuppressed or people that are immunocompromised. So the next one is the UTI. So Pseudomonas is also one of those organisms that can cause urinary tract infection alongside with E. coli, Saprophyticus. Pseudomonas is also one of them. But that of Pseudomonas is very common in people that are placed on catheters. So people that have urinary catheters inside too for a long time, they can develop UTI from Pseudomonas contamination. We should remember that. So people that are immunosuppressed are also at very high risk of developing Pseudomonas infection, particularly people with diabetes. So this diabetes guy typically predispose individuals to Pseudomonas as well as Kleb infection. So it's um there is high risk of an individual that is diabetic to develop Pseudomonas and Klebsiella infection. So we should remember that Pseudomonas and Klebsiella infection is highly rampant in people that are diabetic. So the O is for osteomyelitis. Pseudomonas has some factors that can cause damage, necrosis, that can explain the osteomyelitis, that can explain even the thymic granulation. So one of them is the phospholipase C. We'll talk more about it when we get down. Although the commonest organism for osteomyelitis is Staphylococcus aureus. Even in people with sickle cell, it's still Staphylococcus aureus, but there's high tendency of individuals that have sickle cell anemia, developing osteomyelitis from Salmonella infection. It doesn't still mean that Staph aureus is not the commonest. Staph aureus is the most common cause of osteomyelitis across all population, but you have high incidence of Salmonella osteomyelitis in people with sickle cell anemia. Pseudomonas is one of those encapsulated organisms that we listed. I'm not sure we use a code for them, We just try to list some of them. So, like our group B, Streptococcus, our um, Klebsiella, E. coli, Pseudomonas, Haemophilus influenzae, Neisseria. So, Pseudomonas is also one of them. It is encapsulated. It is encapsulated. It has a mucoid polysaccharide capsule. So that also helps it as a virulent factor. Another thing about Pseudomonas that's moving to from the hem, which is a mucoid polysaccharide capsule, is the O. That's a otitis externa. So otitis externa is predominant in people that has diabetes. So if someone is diabetic and they paint the history that the person is having, otigia is having um, otoria, discharge from the hair, severe hair pain, and they examine that hair, they are seeing granulomatous lesions. They are seeing granulomas, granulation tissue, granulation tissue within that hair. You know that they are likely talking about malignant otitis externa. So this is not otitis media, otitis externa. It affects the external hair, the external acoustic meatus through the pinna. So you are going to notice hair pain. Once you manipulate that hair, it's very painful. You see discharge from the hair and you see granulation tissue. Malignant otitis externa caused by Pseudomonas. Highly predominant in people with diabetes. So it's one of those diabetic defining illness. So diabetic defining illness, malignant otitis externa. You hear something like emphysematous pyelonephritis, emphysematous cholecystitis, um, rhinocerebral mucormycosis. So those four guys, they are DM defining illness. You have to have diabetes to be able to develop those complications. One of them is what we have talked about, malignant otitis externa, which you call swimmer's air because you have to have been in contact with water bodies. And we've said it already that Pseudomonas thrives in water. So people that swim a lot in water and have a lot of water contaminated with the Pseudomonas infection entering their hair, so they can develop malignant otitis externa. Don't forget that. The N is talking about nosocomial infection, just as I've talked about. Healthcare, associated infection that you get from healthcare instruments like catheters, like mechanical ventilation. So we talked about people that have been exposed to mechanical ventilation for a long time can develop Pseudomonas infection causing pneumonia in them because of the fact that Pseudomonas can cause biofilms. We also mentioned catheters, long-standing, causing UTI. Those are healthcare associated infection relating to Pseudomonas. The A is talking about the addiction, injection, drug use. So we mentioned it in our course of in the course of discussing infective endocarditis that um, intravenous drug abusers can develop infective endocarditis from three major organisms. So we mentioned Candida, we mentioned Pseudomonas, we mentioned Staph. So Candida can cause infective endocarditis through intravenous drug usage. Then the last one, which is the hairs, is skin infection. So people that swim a lot or people that have been exposed to hot tubs, can develop hot tub folliculitis. So that's just like inflammatory um, reaction affect inflammatory disease of the follicles, the hair follicles. So they present as rash. Just see rash looking like chicken pox from someone that have been swimming. So once you see the image, you are seeing rash, particularly in the abdomen, looking like vesicles, looking like chicken pox, and they're telling you the person has been exposed to water bodies for a long time. You know that's likely to be hot tub folliculitis they're talking about. The implicating organism is Pseudomonas. Pseudomonas can also cause wound infection in people that have been exposed to some burn injury. So, infection following burn injury, Pseudomonas can easily, cause some bacteremia in those kind of people. So, yeah, so the mucopolysaccharide capsule can contribute to the pneumonia, particularly in people with cystic fibrosis, just like we have talked about, because it can assist with the formation of the biofilms alongside with the slime layer. So the mucoid polysaccharide capsule, the slime all contribute to the formation of biofilm. That's why they can develop chronic anemia. In people that have been exposed to mechanical ventilation for a long time, and also people with cystic fibrosis. So one thing that we have not mentioned about this capsule thing. So we said that capsule is one of those virulent factors that can help for developing meningitis. So E. coli causing meningitis is due to the capsule. You know, um, Haemophilus influenzae causing meningitis is due to the capsule. Another thing that the capsule can also predispose to is pneumonia. So we have not mentioned that. So because this capsule helps them escape phagocytic engulfment. So the alveolar macrophages cannot arrest them, cannot engulf them because of those capsules. So they can cause pneumonia. The microglia of the brain cannot engulf them because of this capsule. They can cause meningitis. So the virulent factor that is making some of those organisms cause UTI is different from what is helping them cause pneumonia or meningitis. So UTI, we are talking about the pili or the fimbriae that they are using to attach to the uroepithelium. So what are the factors or the toxins that are produced by Pseudomonas aeruginosa? So the code is PEEP, P-E-E-P, P-E-E-P. So P is standing for phospholipase C. So do you remember another organism that contains this phospholipase enzyme? Do you remember? We mentioned it. Aside,
Um,
which one? Hello?
no, I'm saying it's called lecithinase for that organism. I'm trying to remember.
Yes, it's called lecithinase for the organism. That's correct.
Now we Clostridium perfringens then.
Yes, yes. Clostridium perfringens. So it can cause, lysis of the membrane, so which can eventually bring about necrosis, and it can explain the reason why it can cause hemolysis. We talked about Clostridium perfringens causing a double zone hemolysis. A double zone hemolysis. The inner zone is a complete hemolysis, beta hemolysis, while the outer zone is a partial hemolysis, alpha hemolysis. That is peculiar to Clostridium perfringens, and it is due to the phospholipase activity that it has. Pseudomonas also has that phospholipase activity, and in addition to that, it also contains endotoxin. Of course, Pseudomonas is a gram negative, so the outer membrane contains endotoxin, which can cause septic shock. So, Pseudomonas, in addition to releasing endotoxin, it can also release exotoxin. And we know the way the exotoxin A of Pseudomonas works. It works alongside with Corynebacterium diphtheria, both of them inactivating elongation factor 2 through ADP phosphoribosylation. The last one, the last P, are the pigments. So, pyoverdine and pyocyanin. They are blue greenish pigments. So those pigments can explain why someone that has pneumonia from Pseudomonas can be producing greenish sputum. You can see someone having UTI having a greenish discharge. It's because of those pigments. Pyoverdine, pyocyanin. Which organism produces red pigment? Anybody? Red pigment.
Serratia.
Russia.
Nice one. Serratia. So this pigment also helps them regenerate reactive oxygen species. So in addition to imparting color, they can also regenerate, they can help them produce reactive oxygen species. So your pyocyanin and pyroverdine helps them generate rather reactive oxygen species that is toxic through the macrophages, through the phagocytes, particularly the neutrophils. So they can prevent immune response because of the fact that they can generate reactive oxygen species through the pigment that they produce. So that's all about PEEP. PEEP, phospholipase C, E. So phospholipase C can degrade anything, can degrade membrane, causing necrosis. So that is why they can cause ecthyma granulosa. That's why they can cause osteomyelitis, can cause so many things, necrotic stuff. Yeah. So E, the endotoxin, septic shock. Pseudomonas causing septic shock, the endotoxin, the E exotoxin, why it can cause some of the other infection, that involves protein, like all these otitis externa, your osteomyelitis too, the other things that it causes, because that's to cause necrosis by inhibiting protein synthesis. So your exotoxin A also helps with that. Then the pigment, generating reactive oxygen so that it can evade immune response. We talked about Pseudomonas causing the keratitis or the corneal ulcers when we're talking about the biofilm formation. So people that are wearing contact lens, you can form biofilms from the contact lens, which can, get contaminated with The contact lens can get contaminated with Pseudomonas, so it will form a biofilm around the lens, infecting, the cornea that the lens is just attaching to, so causing uh, keratitis. We've talked about the erythema granulosum as a necrotic skin lesion caused by the Pseudomonas, and you see it in immunocompromised people. Yeah. So what are the treatments? The treatment. The first thing that we should always remember is that there's a penicillin that can work against Pseudomonas. And this penicillin brand is known as piperacillin tazobactam. So piperacillin is the penicillin itself. That's the anti-Pseudomonas penicillin. The tazobactam is a beta-lactamase inhibitor. So in case your Pseudomonas is releasing beta-lactamase to destroy this piperacillin, it has that piperacillin is already combined with tazobactam, which is a beta-lactamase inhibitor. So it's already available to inhibit the beta-lactamase that can be produced from the Pseudomonas, so that it can't, stay resistant to this piperacillin. So that's why you see most of them coming in combination. Amoxiclav, um, piperacillin, tazobactam, so many combination like that. Yeah, so piperacillin should always come to our mind with respect to penicillin against Pseudomonas. Then the third and the fourth generations too are active against Pseudomonas. So what are these third and particularly ceftazidime and cefepime? Ceftazidime, they use it a lot to protect against Pseudomonas. Ceftazidime is the third generation and cefepime is the fourth generation. So you remember your cephalosporin, you remember your penicillin. Penicillin and cephalosporin go hand in hand. They're like the same thing. So yeah, so um, very similar configuration, beta lactam stocks. Yeah, you have the beta lactam rings. So once you remember your penicillin, piperacillin, tazobactam, you remember your cephalosporin, third and fourth. Then you remember your bactams, monobactams, and carbapenem. They sound alike. They sound alike. So I feel it should be very easy to remember. Although they rarely test the use of this treatment. This is not step two. So with step two now, they can be asking, someone has UTI, what do you want to give? Someone has UTI that is complicated, what do you want to give? For step one, it's very rare. But if you guys want to know it, I think that's the way you can palm it. So you remember your penicillin. You know your penicillin is in close relation with your cephalosporin. You remember both of them like that. Then your bactams, monobactams, carbapenems are like similar stuff. Carbapenems, monobactams. So then fluoroquinolones. Fluoroquinolones are broad spectrum. So they can cover, they have some anti-pseudomonal activity too. So fluoroquinolones. Yeah. So um you want to avoid aminoglycoside because of poor performance in acidic environment. Yeah. So and pseudomonas, you know, thrives in acidic region. It does very well in acidic environment. So if you are giving aminoglycoside, you are basically doing nothing because aminoglycoside will not um hello guys, can you guys still hear me? Sorry, I had a call. Please, can you guys still hear me now?
Yes. Go.
Okay. So remember, Pseudomonas works very well in acidic environment, thrives so much in acidic environment. There are some organisms that can work well in acidic environment. Pseudomonas is one of them. Shigella is another one. So aminoglycoside, have poor performance in acidic environment. They are kind of damaged in acidic environment. So you don't want to give it because it won't work. Yeah, despite the fact that it has anti-pseudomonal activity. Yeah. So let's go to the salmonella and the shigella. So these guys, if we look at the spectrum again, the algorithm. So we talked about the um, the bacilli, and the next thing that we use to classify those bacteria are the lactose fermenting and the non-lactose fermenting. So if you are lactose fermenting, you go to one side. If you are non-lactose fermenting, you go to another side. Okay. If you are non-lactose fermenting, the next test you want to do is the oxidase test. Is it oxidase positive or oxidase negative? So if it's oxidase positive, it can be two things: Pseudomonas or Bacteria cepacia. So if it's oxidase negative, it can be like four organisms. Now we now need to separate those oxidase negative into some category by subjecting them to growth on the TSI Hager. So does it produce H2S on TSI Hager? Okay, if it does, then it's likely to be two things: Salmonella or what? Anybody?
Proteus.
Proteus, fantastic man. So Salmonella or Proteus. If it's not Salmonella or Proteus and it is negative on H2S Hager, it can be what? What are those two? If it doesn't produce H2S on the TSI,
Shigella.
Shigella and
Mm,
so I know that
Yersinia.
eh?
Yersinia.
Yersinia, yeah, that is it. So that's the way to classify them. So we've talked about the Pseudomonas now. We've talked about Buckido, Feral Sepacia. So we are moving down to the H2S guys now.
So, sorry, just to ask you, this is it that they changed the name? Because I used to know Bogdofera, but on this one there is Bocoderia or something.
Yeah, maybe the way you just spell it. You know, some of those spellings can vary. So maybe just didn't pay attention to the spelling. So I'm not sure. I'm not
No,
sure.
because there was Bogdofera
Okay,
something
oh,
something
you are talking
before.
about another thing. Oh, that's Borella Bogdoferi. That's the one you are talking about.
Borrelia Bogdofera. Because
Okay.
that's what you've been saying, You've been saying Bogdofera. Maybe
No.
it's easier for you to say.
Are you serious?
You've not been saying Bocoderia or something.
Okay.
Bocoderia.
That's why I'm always completing it, Sepasha, so that you guys know what I'm saying. So, Bogdoria Sepasha. Yeah, Bogdoria Sepasha. Okay. Yes. So, Salmonella and Shigella. So that's what we are looking into now. They are gram-negative broths. They are non-lactose fermenters, just like we said. They are not oxidase positive. But Salmonella produces H2S, Shigella doesn't. So we look at them um, in three different organisms because they have like similar presentation in a way. They can cause bloody diarrhea. So they can cause bloody diarrhea. So now let's take them one by one. So we have Salmonella typhi. We have like Salmonella um enterica. So it's just like a group of organisms, from the Salmonella genus that contains so many species. So Salmonella typhi is one of them. Salmonella paratyphi is another one. There's a lot of them, But the one that causes typhoid fever is Salmonella typhi. So Salmonella paratyphi is not typhoid. It's not Salmonella typhi, but it can cause an illness that we call paratyphoid fever that can be similar to typhoid fever. So then we have Shigella. So they have different reservoirs. So all the non-typhi Salmonella have their reservoirs both in humans and animals. But Salmonella typhi reservoir is humans only. Shigella too is humans only. But the non typhi Salmonella can be both human and animals. What's the mechanism of spread for the Salmonella typhi? The Salmonella generally is hematogenous. Shigella is not transmitted hematogenously. It has the actin filament just like Listeria that can allow it to move from cell to cell. So the actin filament on Shigella allows it to move from cell to cell without a need for hematogenous dissemination. We've talked about the H2S production. That one is specific to Salmonella strain. Shigella doesn't produce the H2S gas on TSI medium. Salmonella contains flagella, so it can move. Our Shigella is non motile. Shigella is non motile. So Salmonella can swim just like salmon. So salmon is a fish, so it can swim. So that's why Salmonella, we can get it from there. So Salmonella, coined from salmon, can move because salmon can swim. So it has flagella that can allow it to move, while Shigella is non motile. Virulence factor for Salmonella typhi. So Salmonella typhi, both our non-typhi Salmonella and the Salmonella typhi both contains capsule, but there are some serotypes of Salmonella, particularly those of the Salmonella typhi, that contains an antigen on the capsule that we call V-high capsular antigen. V-high, V-high. So it's present on Salmonella typhi. You don't have it on the other ones, on the other form of Salmonella. So the three of them can produce endotoxin. Of course, they are gram negative. They have endotoxins on their outer membrane. So if there's a disseminated infection, they can cause septic shock from there. But in addition to that, on the capsule of Salmonella typhi, there's a VI antigen that can, assist with its virulence. So it can assist in heat causing, protecting it from, immune response and assisting its infectivity. That VI antigen is relevant in our ability to produce vaccine against the Salmonella typhi. So we can produce vaccine against this VI capsule because of the fact that we can obtain that VI capsule. So we can, um, have an immune response towards that VI capsule in the person. So by the time this person is getting infected with Salmonella typhi again, the antibodies are already there to checkmate that Salmonella typhi. So that's it. So we are able to obtain that VI capsule from, a strain of Salmonella. We modify it, make it less pathogenic, then we introduce it into somebody as a vaccine. So once the person gets vaccinated, the person is going to produce immunoglobulins against that VI antigen. It's a protein. So you have immunity. So by the time the person is getting infected again with the Salmonella, having that VI capsule, they can quickly respond to it and they can kill it off. But because of the fact that you don't have that VI capsule on the other Salmonella strain, you don't have vaccine against them. There's no vaccine against Shigella. So what is the infectious dose? That is the dose that you need to cause, infection. That's infectious dose. That of Salmonella generally is high because Salmonella doesn't have acid resistant mechanism. It cannot protect itself from acidic medium. It gets damaged. So that means that you have to have inoculated a lot of dose of Salmonella before you can have some that will bypass the acidic region in the stomach and get to the intestine where they cause their problem. So just imagine that you deliver, like, let's say that the liter dose the infectious dose that you need is like 50. So if the person gets infected with 100 and 60 gets damaged by the gastric medium, 40 escape into the intestine, that 40 will not cause infection because it doesn't meet to the minimum requirement, which is 50. So the acidic medium in the stomach actually helps to damage um, Salmonella. So that's one way that we can be protected. So people that have maybe pernicious anemia or any condition that can cause achlorhydria or hypochlorhydria, and the gastric acid level is very reduced, they can develop Salmonella infection easily. But for Shigella, they have some intrinsic mechanism that make them resistant to gastric acid. So you need a very small dose, a very small inoculum, to cause infection. Just very small amount is required to bring about the infection from Shigella. What's the effect of antibiotics on the fetal excretion? So the way you can remember this is that Salmonella is an intracellular organism. So it stays part of its life cycle occurs within the macrophages. So some of them spend some time in the macrophages, some of them are outside. So because of the fact that it's a facultative intracellular organism, it can spend some time within the macrophages. So it can be protected from antibiotic insults. So if you give someone that has Salmonella typhi antibiotics for a long time, what will happen is that those antibiotics are going to kill off the normal flora. Those normal flora are even there to help you control the activity of your salmonella so that it doesn't exert too much damage to the body. It's just like Clostridium difficile. Your microflora are there to help them silence and quieten all those guys. Now, once you have used too much antibiotics and you have killed off normal flora, Salmonella typhi start proliferating. Your antibiotic might not be able to get to your Salmonella because it spends some time intracellularly, so it will be protected. So that means that they will keep proliferating and you can shed a lot of Salmonella in stool, because the sites of colonization of the Salmonella and your Shigella at the end of the day are your intestine. Intestine is where they are going to. So once they pass through the GIT, once they are taken fecally, they go down the esophagus to the stomach, intestine. That's where they start causing problems. So something that is proliferating in the intestine will eventually find its way in the stool. Yeah. But Shigella is not intracellular. Once you give antibiotics towards Shigella, it will kill off the Shigella, and you have less shedding of Shigella in fecal, matter. So, in a way, antibiotics administration can actually um, increase the risk of transmission of Salmonella typhi, because it increases the amount of Salmonella that is passed in the stool, and there's increased tendency of those fecal matter contaminating water bodies, and another person can take it from there and acquire the infection. The immune response, yeah. So one way to understand the immune, the pathophysiology of these guys when it comes to disease causation is that once they are injected fecally, they travel down, to the GI, they stop at the small intestine. So when they get to the small intestine, they migrate into the Peyer's patches. I know that Dr. Barani have talked about the Peyer's patches. So what are the Peyer's patches? Anybody?
The spinal lymphoid um, lymphoid cells.
Okay. Lymphoid cells where?
The GIT. Associated
Is it in
lymphoid
the
tissue,
colon?
molds, they are
Is it in the
more.
colon?
No, in the intestine, in the small intestine.
Okay, yeah. So they are kind of lymphoid tissue that you find in the intestine. So what they do is that they contain some cells that we call the M cells. So the M cells is just there to just process all the antigens from the infection that is traveling to the small intestine. So they process them, they present it to the lymphocytes that are present within the lamina propria. That's what they do. So you present them to the immune cells so that they can respond to it and you can have an immune activation. But in people with salmonella, so once you have um your your salmonella getting to the small intestine, they have some intrinsic mechanism that allows them enter, into those M cells. They proliferate within the M cells of the Peyer's patches, and from there they are being, engulfed by macrophages. So you guys know that monocytes are what will eventually differentiate into macrophages once they get to the tissues. That is it. Monocytes are just white blood cells in the blood, right? You guys know. Okay, maybe you have not gotten there. So
Yes,
okay.
yes, we know that.
So once monocytes get to the tissue, they differentiate into the specific macrophages that we are looking at. So they get taken up by the monocyte macrophages. That's that about Salmonella typhi. They proliferate within those macrophages and they travel around the body. So they can go to different parts. They can go to the liver, they can go to the gallbladder, they can go to the brain, they can go anywhere, because of the fact that they are engulfed by those monocytes. But it is not monocytes that respond um to the non-typhi Salmonella and Shigella are the Peyer's patches. It is not. They are the neutrophils that respond to them. So neutrophils is what we engulf our um, Salmonella and Shigella to try to damage them. So they try to engulf and digest them. So that is that about Shigella and the non-typhi Salmonella. But for typhi, it is monocyte or macrophages that respond to them. Yeah. So this typhi can actually survive within those macrophages for a while. So it can proliferate within those Peyer's patches, it can proliferate within those macrophages, and that is the reason why you have constipation happening before diarrhea. Why? Because when it proliferates within those M cells, It causes hypertrophy of the Peyer's patches. And you guys know that the Peyer's patches are part of the small intestine. So there is narrowing of the lumen of the small intestine, and it kind of causes an obstruction to passage of fecal matter. So constipation is one of those classic findings of Salmonella typhi. Typhoid. They have constipation, then afterwards diarrhea happens once the organism is able to leave that area and travel down into the small intestine to the to the large intestine. That's when it now starts attacking the mucosa of the large intestine. Then they can now cause diarrhea that is bloody. Okay, although we are still going to talk about some symptoms that happened before that. So we have two types of vaccine against the Salmonella typhi. Two vaccine, the oral and the IM. So the oral one is a live attenuated vaccine. So it contains the live organism. The organism is living, but it's kind of subdued. So once we quieten it a little, we make it less pathogenic, but it's alive. We call it the live attenuated. You don't want to give that kind of vaccine in someone that is immunosuppressed or someone that is pregnant. Why? Because those kind of people, you can easily have a pathologic activation of that organism, and it can cause serious pathology in them. So it's just like giving somebody oral polio vaccine. What you are trying to achieve is production of immunoglobulins against the polio vaccine, against the polio antigen. Now you are now giving that polio vaccine to someone that is immunosuppressed, and the person now develops polio. You have injured that person. So you don't give live attenuated vaccine to people that are immunosuppressed. So before we develop this oral vaccine that contains the live attenuated staph um, um, Salmonella typhi, we were using the IM vaccine, the one that you give intramuscularly. So that one just contains, the VI capsular. So you are not taking the whole organism. You are just taking the VI antigen, the VI capsular polysaccharide. That's just what you are taking. You are introducing it into um the individual, and you are trying to achieve immunity with that. Although that one will not be strong as you giving the whole organism that contains or the protein specific to that organism and all those. So you are only giving the capsular polysaccharide. You are not going to mount a very strong immune response like the oral vaccine. So we said the reason why there's no vaccine against the other one. So there's no vaccine against the non-typhi as well as Shigella. Yeah. So what are the unique properties of these guys? Salmonella typhi can cause typhoid fever. Yeah. One thing is peculiar to that type of fever. We call it rose spot. Rose spot. So once you guys see in a question and there's making description of a rash that is rose colored or looking like a rose flower or something, that is likely to be typhoid fever. So it's just due to bacterial emboli of the organisms to the skin. That is it. Blood vessels of the skin. There's embolization of those bacteria to those blood vessels. Those are those things that causes, the rose spot or the salmon colored truncal malaria. So you typically see them within the truncal aspect of the body. So because of the fact that there's proliferation of the organism in the small intestine, the large intestine, invading the mucosa, it can cause abdominal pain. Of course, an infection. It causes fever. But there's something we call the master rule. So that rule, I don't know if you guys are aware of it. So you have um for each Fahrenheit increase in temperature, you are supposed to have about 8 to 10 beats per minute increase in the pulse. I don't know if you guys have heard about that. The Bamister rule. Hello, guys.
Yeah, I don't know it as rule, but I know
Okay.
that
Yeah,
there's always a 10 beats per minute rise in pulse for every rise in temperature.
exactly. So that is it. So you don't have that in someone that has typhoid fever. So typhoid fever is one of those things that can, you know, go against that rule. It doesn't happen. So there's a dissociation between pulse and temperature in someone that has typhoid. It's not only typhoid fever that can cause that. Someone that has yellow fever, it happens in them too. It happens in them. So we call it relative bradycardia because you are having fever and you are not having a commensurate increase in the pulse. So you can say that is the relative bradycardia. So relative bradycardia, abdominal pain, fever, rose-colored rash, or salmon-colored truncal rash. Then after they attack the GIT, there is necrosis, there is ulceration of the GIT, bringing about the bloody diarrhea. So you can treat it with some antibiotics like ceftriaxone. Just give him short course ceftriaxone, fluoroquinolone. It can help. But we said it that the macrophages can take it, so many part of the body. They can go to the bile, they can go to the gallbladder, they can go to the liver. So it's being observed that Salmonella typhi colonizes the liver, the gallbladder. So some people can have Salmonella typhi in their gallbladders, colonized, in that area. So those guys are carriers. So it can easily move out of the gallbladder and find its way into the bloodstream and cause, sepsis or anything afterwards. So those ones are actually at high risk of, from there they can even move through the bile into the GI, into the feces, then they can spread it to another person through fecal matter. Yeah. So people that are carriers of Salmonella typhi due to gallbladder colonization are at very high risk of transmitting the infection to another person. So don't forget that Salmonella typhi can colonize the gallbladder. That is a very unusual stuff, but you need to know it. It colonizes the gallbladder. So they have a high predilection for staying in the gallbladder. So they can be secreted in bile. From there, they enter the intestine, the duodenum, they find their way into feces, and they can be transmitted to another person. Yeah. So,
Like,
yeah, Doctor.
since you said that antibiotics causes like an increased colonization, like it prolongs their stay.
Yeah,
Now,
that's why I
now that
said
I
short
really
course. That's why I said short course. That's why I said short
shoot.
course. Yeah. So, the non-typhy ones, you find them in animals like all these, you know, like our poultry, the fowl and all those things. So they can be in dogs, goat, and all those things. Animal sources. So most of the time, they don't cause very serious infection. It just cause maybe a very low grade gastroenteritis that is not very severe. You don't usually need to give them antibiotics. You don't usually need. You just support it. Just give them fluids. That's all you just do. And maybe antibiotics if there's fever. But in some situation, you can have complications. So they can cause liver problem. They can go to the brain and be causing brain issues. They can cause so many issues. So if it's complicated, they can even go to the spleen and be causing splenic abscess. So once there is complication from salmonella, which is very very unlikely, the non-typhic salmonella there is complication, you might want to give antibiotics. So I forgot to mention some of those complications of typhoid. We said it, I can travel to so many areas. So it can go to the gallbladder, it can cause cholecystitis, it can cause splenic abscess, it can cause liver abscess, so many things. So many things. So although they rarely ask about those complications, sha, it can even cause endocarditis. It can go to the heart and cause endocarditis. But if you have somebody having the non-typhi salmonella that is associated with some complications, you might want to give them antibiotics. You know, that is that.
Dr. Babali,
Yes,
sorry. The M cell one is Shigella, not Salmonella B.
the M cell.
Salmonella is the Peyer's patches, right?
No, I don't understand, Dr. Toby. Come again, question.
Of M cell, like M cell has to do with Shigella, not
No,
Salmonella
no,
B.
the three of them. The three of them. The
Also,
three
it
of
can
them.
affect M cell. The three of them affect M
Yes,
cells.
the three of them
Okay.
proliferate in the M cells. The three of them. The three of them.
What of Peyer's patches?
Yeah, like M cells of the Peyer's patches. Do you get?
Thank you. Thank you.
Yeah.
Thank you.
So, um, we've talked about the Salmonella typhi and the Salmonella non-typhi. So looking at Shigella now, we've talked about the fact that the dose is very small because it can resist the acidic region, so you need very small amounts to cause problem. Um, it's being transmitted. It's the neutrophils that predominantly respond to it. So Shigella typically affects the colon. That's where it lies. So it goes down to the colon, to the rectum, causing rectal inflammation, you know, affectation of the other side of the colon. And once there is affectation of the rectum, it causes tenesmus. You guys know that tenesmus is one of the cardinal signs of rectal cancer. I hope you are aware of that.
Yep, yep.
Yeah, so someone that has tenesmus, you are thinking of rectal involvement. So the person is not able to empty all the bowel content. So the person goes to the toilet now, just few minutes after, feels that there's incomplete emptying, he rushes back again. That's tenesmus. Feeling of incomplete emptying of the bowel, tenesmus, is actually due to, proctitis, like inflammation of the rectum. So there is Shigella invading the mucosa. You guys know that Shigella can invade the mucosa, unlike enterohemorrhagic. Abi now, guys, enterohemorrhagic doesn't invade. Abi, hello.
No, it
Yep.
doesn't.
Yeah, there's no catch there. There's no catch there. It doesn't invade. So, but because both of them can actually release the Shiga toxin. So, the Shigella itself can invade it, damage it. Then it cannot even now release its Shiga toxin that will cause the necrosis because it inhibits protein synthesis too. That cause the necrosis and the ventral mucosal ulceration, which brings about bloody mucoid stool. That's what you see. That's what we call bacillary dysentery. So, tenesmus with crampy abdominal pain because there's, pain, inflammation of the colon, the rectum, everything. Those causes those crampy abdominal pain. Then the tenesmus is particularly talking about affectation of the rectum. Then the bloody mucous too. Although that one is not specific, it can happen in any one of them. But once you are saying the tenesmus, crampy abdominal pain, you are thinking of Shigella. There's no vaccine. They can be transmitted through the all these things. So the fingers, the flies, food, and feces, we understand it. So food that is contaminated with flies, flies can settle on the fecal matter that contains the Shigella. So once that fly, stays on the food, it has transmitted it already. So people that they use the toilet, they don't wash their hands properly after cleaning their bum bum. The bum bum is infected with the fecal matter, and they find a way maybe into the kitchen, they are making meal, they don't wash their hand properly, they inoculate that organism into the food and they take into their body. That's the way. So the four F's: so flies, finger, feces, and then food. Yeah. So in order of decreasing severity in terms of the toxin that is produced, Shigella dysentery is the most pathogenic, produces most abundant toxin, then followed by the flexneri, the poidy, and the sonic. Nobody will ask us all these things. Nobody will ask us. So if you want to know it, it's fine. So we've said that they both invade the M cells and they cause the problem from there. Yeah. So another one is Yersinia enterocolitica. One thing I just want to say about this Yersinia guy is that once you see any presentation that is similar to acute appendicitis, Yersinia enterocolitica should come to your mind. Yersinia enterocolitica is also one of those organisms that can attack the GI mucosa and cause dysentery. Campylobacter jejuni is one. We have talked about it stylishly. I think have we talked about Campylobacter? No, no. But I mentioned it. Yersinia enterocolitica is another one. Shigella, Salmonella. They invade those mucosa, they cause damage to the mucosa, and they can bring about dysentery, blood diarrhea. But one thing that is peculiar to this Yersinia again is that once it is ingested, it travels to the small intestine and colonizes the lymph node, causing mesenteric adenitis, as well as terminal ileitis. It causes inflammation of the terminal ileum, as well as inflammation of the lymph node draining the, the intestine. So there's mesenteric adenitis and terminal ileitis. So because of that, they cause a right lower quadrant pain. So they cause a right lower quadrant pain because of the affectation of this lymph node as well as the terminal ileum. So you know that the terminal ileum is just continuing with the cecum, and cecum is located on the right side of the abdomen, right lower side of the abdomen. So they can cause pain that is very similar to appendicitis. That's why they call it pseudo appendicitis. So once you remember, okay, the bloody diarrhea, because of invasion of the GI mucosa. It causes inflammation of the lymph nodes as well as um the terminal ileum, causing terminal ileitis. Then it's also one of those organisms implicated in reactive arthritis. We have a lot of organisms in reactive arthritis. Once you hear reactive arthritis, one thing that should always come to your mind first is Chlamydia trachomatis. That's the commonest cause of reactive arthritis. And when we are saying reactive arthritis, what is the triad? Do you have anybody that remembers the triad of reactive arthritis? We've done it in musculoskeletal.
Can't pee.
Can't
Uveitis,
be, can't see, can't be
uveitis,
immune.
Okay, Dr. Abisola,
Uveitis,
let Dr. Abisola,
urethritis, and arthritis.
okay, maybe
Can't
Dr. Abisola should say it so that I can tell Dr. Abisola.
can't pee. Urethritis. Can't
Okay,
see. Uveitis and the
okay,
arthritis can't
okay,
work
yes.
properly.
They can cause conjunctivitis, uveitis, eye problem. They can cause urethritis and joint still. So, uh, I think chlamydia. So that's nice one. So
What's MSP? You said MSP.
multiple
Multiple
sexual partner.
sexual partner.
Yeah. So watch out for that. Chlamydia trachomatis is the commonest cause of reactive arthritis, not gonorrhea. Don't go and fall for gonorrhea. Not gonorrhea. Yeah. So another one that can cause it is also Yersinia. Our Campylobacter jejuni can cause it. So what about this Yersinia? So it's pleomorphic. It can be rod and it can be cocobacilli, depending on how it decides to be. So it's pleomorphic and it's gram negative. So um bipolar staining, okay, so you can see like two poles. Once you are looking at the organism, you see like looks like having as if that's two poles. Yeah, so it can be transmitted from pet feces like cat, dogs, contaminated milk and pop. Yeah. You guys can. It's not very high yield. Nobody will be asking you the route of transmission of Yersinia. They will most likely ask you to make the diagnosis of the organism from the presentation. So they can make presentation of body diarrhea with appendicitis-like symptoms. Then they will ask you what is the presenting organism. Okay, so lactose fermenting bacteria, we've already talked about them. We mentioned the fast fermenting and the slow fermenters. The slow fermenters are what? Which ones? Which ones are the slow fermenters? Our Citrobacter,
Serratia and
Vitro.
Stropbacter.
yeah, Sriracha and Citrobacter. Then the fast
Yes,
ones, E.
yes,
coli, Kleb,
yes, C.
and Entero.
Equal and clip. Yes,
Yeah.
yes.
So one way we can separate them is that E. coli can be distinct from these guys. When we culture E. coli in EMB, that's the eosine methylene blue agar. So we said it then that E. coli will appear as a green,
Metallic.
yeah, so the green
Yeah,
metallic
green
layer.
metallic shame.
While the other ones, if you put them in that EMB agar, they will appear black or purple. Which other organism appears black in its agar?
Cryptococcus.
No, 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 no. I
You
get what
come
you're
and
trying.
Sabi.
I get what you're trying to do with that.
Cryptococcus black.
No, 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 no.
Kiloton black.
It's not equivalent.
Hemophilus influenza.
In which medium? In
Hey,
chocolate
God,
agar?
oh, God, oh. Chocolate agar.
No, 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 no. It's not hemophilus.
Hey, jeez.
You see black colonies. Black colonies.
Black. Oh, this thing is tellurite agar.
Tellurite agar. Corynebacterium diphtheria.
God.
Tellurite agar. Black. So,
Conivactive. God of mercy. And metachromatic granules, right?
yeah, metachromatic granules in
God.
our low flare medium. So you see them
It is well.
blood cells. Okay.
It is well.
E. coli. So we are picking those lactose fermenters one by one now. E. coli, E. coli. Now, E. coli is a gram negative. We know that it is Indo positive. Indo positive. Indo is just testing for one enzyme that I'll call like tryptophanase. So that enzyme can break down tryptophan into Indo and it will give it purple color. So once you put the medium contain that tryptophan into a tube and you add E. coli or any organism to it, once the organism is able to break down that tryptophan to Indo, it is Indo positive. E. coli is one of those Indo positive agents. There are so many other ones, but E. coli is the most commonly tested one. You just stick with E. coli so that we don't complicate, the stuff. Another thing about E. coli is that the way you can make diagnosis of E. coli fast. You guys remember that E. coli is highly involved in UTI. So, and that is the disease, or that's the pathology that they most likely associate E. coli with UTI. So they will just bring out the urinalysis result and they will tell us that it is nitrate positive. So, and it's leukocyte estuary positive. So once you see that nitrite positive, most of the time E. coli will be what you are looking at. E. coli. The leukocyte estuary positivity just means that it is an infection. But which one is it? So nitrite positivity, you think of E. coli. You think of E. coli. So what are the variance factor of this E. coli? Number one, the fimbriae. So the fimbriae can explain the reason why it can cause UTI, cystitis, and pyelonephritis. So if cystitis is causing pyelonephritis, that's a complicated infection. It has ascended. That's what it means. So most likely, someone that has cystitis, you will not see fever, you will not see chills. Guys, once you are seeing fever, chills in a UTI, it is pyelonephritis until otherwise proven. Cystitis doesn't cause systemic manifestation. It doesn't cause fever, no chills. So once you are seeing fever, chills, you are seeing costovertebral ankle tendon. Although costovertebral ankle tendon doesn't give it out, it doesn't separate it. You guys know that there are so many things that can cause costovertebral ankle tenderness. Even someone that has common interstitial nephritis from use of drugs, they can have costovertebral ankle tenderness. You just know that the kidneys is problematic. So fever, chills, urinary symptoms like dysuria and all those things. With costovertebral ankle tenderness, we are thinking of pyelonephritis. Without that, someone just having suprapubic tenderness, dysuria, no fever, no chills, cystitis. Yeah. So what helps them to colonize and attach to the uroepithelium are the fimbriae. So example of that fimbriae is the P. pili. So the pyelonephritic pili. That's the full meaning of this P. pili. Pyelonephritis pili. It has a capsule that we call the K capsule. That K capsule is what helps it cause pneumonia. So we've talked about it. That capsule will help it avoid the alveolar macrophages so that it can cause pneumonia, then avoid the microglia so that it can cause neonatal meningitis. Of course, we expect it to cause neonatal meningitis. It's not one of those cause of meningitis in the adults like strep pneumo, like Neisseria, and the likes, or Haemophilus. So all these listeria, E. coli, they cause neonatal, or group B streptococcus, they cause neonatal meningitis. The last one is the LPS endotoxin that explains the septic shock that they have. So, what are the different strains of E. coli? We have four different types. The enteroinvasive. So these ones are very straightforward. From the name, enteroinvasive, it invades the intestinal mucosa, causing cell death, necrosis, and inflammation. Bam, that is it. So you are going to see bloody diarrhea, dysentery, very easy. That's all about enteroinvasive. Enterotoxigenic, that one produces toxin. It doesn't invade. What are the toxin? The heat stable and the heat labile. We know the way this enterotoxin works. They don't attack, they don't invade, they don't cause inflammation. It is a toxin, that alters the dynamics of the epithelial cells of the intestine, causing the symptoms. So they will, activate the GS, and make CMP much more available, which can, cause um, secretion of sodium and chloride and water into the lumen, causing the diarrhea. So the enterotoxigenic is notorious for causing traveler's diarrhea. So traveler's diarrhea is someone having diarrhea while they are traveling to endemic countries like Latin America, Southeast Asia, and all those areas. That you have all these E. coli strain. So once they travel, they tend to stop along the way to drink water. So they take water from polluted sources that contains all these organisms, and they can develop diarrhea. So E. coli is not enterotoxigenic. E. coli is not the only one that is implicated, but it's the commonest. So Giardia can also cause traveler's diarrhea. Giardia, but the commonest one is E. coli contaminating water bodies, especially in countries with very poor sanitation, are very dirty. So you can have E. coli in this water, and just taking the E. coli produce a toxin, and they have the diarrhea. So that we call them traveler's diarrhea because it's more common in people that travel to those endemic areas. Enteropathogenic E. coli. This one doesn't produce toxin and it doesn't invade. So what it just does is just to adhere to the epithelial surface and flatten, it blunts out the villi, preventing absorption of fluid. So, you need that villi to absorb fluid from the lumen, into the epithelial cells like sodium, and so it doesn't allow absorption of the electrolytes. So the electrolytes accumulate within the lumen and cause diarrhea. So this is the commonest cause of diarrhea. It's very common in people that are small, the children. Enteropathogenic E. coli. It just adhere and flattens the villi, obliterates the villi. That's what it does, preventing absorption. It doesn't produce any toxin. The other one that produces toxin aside the enterotoxigenic is the enterohemorrhagic, which you are very, very familiar with. So the strain of this enterohemorrhagic that we are looking at is the O157H7 serotype. So that's the serotype that caused some problem in the 1950s. You have it in your uncooked meat, vegetables, food generally. So it produces the sugar toxin. That particular strain can produce the sugar toxin that works exactly like Shigella, causing hemolytic uremic syndrome. I'm sure you guys already know what hemolytic uremic syndrome is all about, so we don't need to talk about it again. We have explained it a lot of times. So they release the sugar toxin that can cause necrosis because of inhibition of protein synthesis and inflammation, causing dysentery. It doesn't invade. It doesn't invade. It is only enteroinvasive that invades. So another clincher for this enterohemorrhagic is that it doesn't ferment solitol. That one is not high, but if you guys want to learn it, it's okay. It doesn't ferment solitol. So the next one, for the list of the lactose fermenting organisms is Klebsiella. So Klebsiella can ferment lactose just like E. coli. It's a gram-negative rod. It's one of those
Dr.
commensal.
Babali. Hello, Dr. Babali.
Yeah,
Hi, can you hear me?
yeah, I can. I can.
Um, which one of these causes neonatal meningitis?
Neonatal meningitis. That's
Which
E.
one?
coli. That's E. coli.
Which one of them
Okay, which one of
specifically?
them?
Is it all of them? Yeah.
Uh, well, I'm not pretty
K
sure.
capsule, anyone with K capsule, abi?
Yeah, like all of them have a capsule, but I'm not pretty very sure about the one
Okay.
that causes it. But I think
Thank you.
I think this strain actually look more concerned with the strain
About
that causes
diarrhea.
diarrhea. So there are so many strains of E.
Yeah.
coli. There are so many strains of E. coli. So I think these ones are particularly the one that causes diarrhea only. So that is it.
Okay, thank you.
Yeah. So Klebsiella. So we've said it before that Klebsiella is very common in individuals that are immunosuppressed, particularly people that are taking alcohol or people that just have impaired host defenses like diabetic
Okay,
people.
Babawale,
Yeah, Dr. Olushara.
I checked Google now. I think there is another strain of the one she talked about, neonatal meningitis causing E. coli. They put
Okay.
it separately.
Yes, yes. There are so many strains. There are so many strains. There are so many strains. So that is it. There's another strain that will be causing UTI. All these enterohemorrhagic, these ones will not cause UTI. So these ones are only for diarrhea. So that is it. So yeah. So someone that is taking a lot of alcohol, that is diabetic, there's high chance of them getting Klebsiella infection. One thing again that I want to mention about Klebsiella is that it is notorious for causing abscesses. So you tend to find Klebsiella, causing liver abscess and lung abscess. So aside Staph aureus, aside the anaerobes, Klebsiella is another organism that you can culture from lung abscess. So people that are drunk, taking a lot of alcohol, or they don't have a patent airway, they can have aspiration pneumonia from you know Klebsiella. You know, when they aspirate the gastric content into the airway, Klebsiella can find its way into the lungs and can cause aspiration pneumonia, which can progress to developing into a lung abscess. So Klebsiella is just one of those organisms that doesn't stop at causing the pneumonia. They further wall off that damage that they are causing, forming a cavity, which eventually develops into abscess. Staph aureus is also notorious for doing that. Staph aureus. Klebsiella is another organism that is also notorious for causing abscesses. So lung abscess, liver abscess, Klebsiella. So Klebsiella can move away from the intestinal epithelial cells and enter the blood. In the blood, it can find its way to the portal vein and get to the liver and cause portal abscess and cause liver abscess rather. So abscess generally, you are thinking cleft, lung abscess, liver abscess. The abscess can come from aspiration pneumonia. So after they have aspirated GI content from maybe they don't have a patent, they don't have they are not very conscious, be someone that is unconscious, or someone that is drunk, alcoholic, or someone that has a stroke. They can easily aspirate and they can develop lung abscess that contains the Klebsiella organism. So Klebsiella has very thick mucopolysaccharide capsule. That thick capsule is what makes it appear like this. Which other organism contains a very thick capsule? Anybody? Very thick capsule. Anybody?
Is it crypto?
Yeah, Cryptococcus neoformans contains very thick capsule. So Klebsiella also contains very abundant and thick capsule. So that's why it looks mucoid like this. Mm. Those are the capsule making the colonies, appear, mucoid and thick like this. So it's infection from Klebsiella, particularly pneumonia, you know, that is caused by Klebsiella. The typical color of the sputum that they produce is coral jelly. So it contains some blood tinge. It's like, you know, blood tinge. So call it coral jelly sputum. So we should we should remember that. We should remember that coral jelly sputum, that contains a mix of blood and mucus, Klebsiella is implicated in that. It's a cause of healthcare associated UTI, okay, and Klebsiella is also is undergoing evolution for developing into so many strains that are actually resistant to some drugs. Yeah. So, but the high yield fact about Klebsiella is the fact that it can cause it's just exactly what they have listed here. This ABCDE. They can ask you any one of those facts. You must learn it. ABCD, the aspiration pneumonia, the abscess in the lungs and the liver, the red collant jelly sputum, which contains a mix of blood and mucus. Then the fact that it's very common in people that are diabetic or people that take alcohol. So that's that about clear. It can cause UTI. It can, because of the fact that it's an enteric organism, so it can easily contaminate the genitourinary tract that is just anterior to the gastrointestinal tract. So it can ascend from there and cause UTI, just like E. coli. So, healthcare associated, you guys know why. So when you are trying to use your equipment or something, you can, maybe you are trying to catheterize, so you can contaminate the catheter, you know, with maybe enteric flora or even from your own hands. So, and you can introduce into genitourinary tract from there and can cause UTI. So, although the commonest one that you see from use of genitourinary or gastrointestinal procedure is what? Our enterococcus. So, that is that. So, Campylobacter jejuni is also a gram negative. It is coma shaped. So, it's one of those coma shaped rod that we talked about yesterday. The three coma shaped rod, they are oxidase positive. What is peculiar to Campylobacter jejuni is that it is it can grow at 42 degrees Celsius. That is its own stuff. It's one of those causes of bloody diarrhea. I've mentioned it alongside with Yersinia and our Salmonella and Shigella. It typically causes diarrhea or dysentery in children. So you can transmit it from once you pasteurize milk, from food items, poultry, meat, and all those things. And it can be an antecedent infection to developing Guillain-Barré. So that's one of those things that brought Campylobacter jejuni to the spotlight. So it's been noticed that, you know, few weeks or few like months towards developing GBS, there's a history of infection with Campylobacter jejuni or Zika virus. So Zika virus now also coming into the picture. So it's either can be Campylobacter jejuni or Zika viremia. Campylobacter jejuni is also one of those guys that can cause reactive arthritis. So the pathology that concerns Campylobacter jejuni is just dysentery, GBS, and reactive arthritis. That is all. That is all about Campylobacter jejuni. So once you are seeing them portraying a ground thin, comma shaped, cuff shaped or comma shaped rod, you know that they are likely talking about three things. It's either it's vibro, it's Helicobacter, or it's Campylobacter jejuni. So from the presentation, you can narrow down the one we are looking at. Okay. Yeah, so vibro, that's the second of the cupped bacteria. It's
So, about it,
yes, Dr. Mishala.
wait, can you help me summarize the Campilo again? Sorry.
So I said the Campylobacter jejuni is one of those comma shaped bacteria. It is oxidase positive and it grows at 42 degrees Celsius. So I said the three things that they can ask you about it is that you need to know rather is that it's a cause of bloody diarrhea, it's an antecedent infection to developing Guillain-Barré syndrome, and can also cause reactive arthritis. So that is it.
Okay, thank you.
Vibrio cholerae. So vibrio cholerae can cause cholera. That's the organism that causes cholera. It's also one of those gram-negative fragmented comma-shaped organism. It's also oxidase positive. We've talked about it that the three of them are oxidase positive. The peculiarity for vibro is not that it grows at 42. No, this one can only grow in alkaline media. So that's why it can even sustain it grows within the small intestine and and cause cholera. So you can find it in very very poor countries, developing countries, all these countries that the sanitation is not optimal. So they tend to come down with cholera. And then that's because of the rice water diarrhea, and it's due to the cholera toxin that permanently activates GS. So we remember that once there's permanent activation of GS, there's increased CMP, and there is increased secretion of sodium chloride, in the lumen causing the diarrhea. So vibrio cholerae is sensitive to stomach acid. So it's just like salmonella. So anybody that have anything that causes reduced gastric acidity, they are predisposed to developing vibrio cholerae too. So you can get it from contaminated water or from contaminated food, particularly raw shell fish. So we actually need to pay attention to this one. They can ask this one. I mean, the way you can get cholera, raw shell fish, very very important. Uncooked raw shell fish or contaminated water. How do you treat it? ORS is what you need. Supportive treatment. Just give them solution of water and salt to reconstitute all these things that they have lost through vomiting and diarrhea. Yeah. So there's another form of vibroorganism that we call vibrophonificus. Vibrophonificus. If you see this vibrophonificus, one thing that should come to your mind is either the person has a liver issue. Most of the time, you know, the individual will have a liver issue, particularly hemochromatosis or maybe thalassemia or something that is causing iron overload, which is now affecting the liver. So it's associated with cirrhosis, especially cirrhosis that's secondary to hemochromatosis, because this organism is one of those organisms that actually thrives in iron-rich environments. So it kind of proliferates very well, and it uses iron in its own metabolism. So someone that has hemochromatosis has a very high chance of getting infection with this vibrio phoenificus if the person is very close to a marine environment, because you find them in salt water. That's where you find them. What do? They don't cause diarrhea like typically. What they cause is wound infection. That's what they cause. So they cause wound infection. That's the thing that they contaminate wound and cause like necrosis of that wound. For that, you know, extend the damage, and it can even disseminate in the blood, causing septicemia. So once somebody is exposed to still water that is contaminated with the vibrio phoenificus, they can develop wound infection and consequent septicemia. So the wound infection can, present as cellulitis, and it can even progress to necrotizing fasciitis, particularly in high-risk individuals like in with the liver issue that we have talked about. So that iron overload within the blood can, make them, um, proliferate extensively, and they can cause more damage. So you need to debride down because of the necrosis that it causes. You need to debride. You need to remove those necrotic um, matter so that you can have eventual healing. Because if you don't remove those necrotic bodies, there are fertile sites for those guys to continue proliferating. So you need to debride, then you know achieve resolution at the end of the day. Yeah. So I'm not sure I'm aware of any antibiotics that they use to treat that organism. I'm not sure they will ask us that. Yes. So Helicobacter pylori. Helicobacter pylori is also one of those high-yield organisms that they ask a lot, a lot. So, of course, we know something about it before. It's flagellated, it's motile because of the flagella. It's cupped. It's one of those cupped guys. This guy is triple positive. It's positive for oxidase, for catalase, and for urease. Oxidase, catalase, and for urease. So, because of the catalase, it can cause CGD. Because of the urease, it can cause ulcer, can cause peptic ulcer disease. So, that urease positivity is also one of the bases for detecting it through the breath test. So it breaks down the urea into CO2 and um, what's it called, and ammonia, so you can detect the CO2 in the air, because the CO2 will diffuse out of the body into the atmosphere. So that's why the CO2 doesn't stay and be causing problem. It is the ammonia that will stay and neutralize the gastric acid so that it can stay within the stomach. And we remember that H. pylori actually colonizes the antrum of the stomach. That's where it stays. So it will start digesting urea to produce CO2 and ammonia. So the CO2 is going to move out of the stomach and find its way outside through the atmosphere, while the ammonia will stay and neutralize the acid that is surrounding the antrum so that the H. pylori will not die. So that ammonia that is also releasing will also neutralize the acidity of some portions of the stomach, and that will activate the G cells that will make them secrete gastrin. So when gastrin is abundant, it stimulates, the parietal cells to begin to release acid. So the acid will now flow down from the stomach to the duodenum. The duodenum before is not tolerant to acid like the stomach. So that is why you tend to have more cases of duodenal ulcer being from Helicobacter pylori. 70% of gastric ulcer is from Helicobacter pylori. 90% of duodenal ulcer is complicated with H. pylori. 90%. So once you see someone having duodenal ulcer, you want to rule out H. pylori in that person. But 90% of the time, you'll be correct. Yeah. So that's the pathophysiology. That acidic damage, you sorry, I said acidic, yeah. What's it called? So the urea that is released into the environment can also cause the chronic atrophic gastritis. Then um uh you know it can also cause intestinal metaplasia, because at the end of the day there will be transformation of the mucosal epithelial cell. So if you want to assume those of that of the intestine because of the chronic exposure to the acid. So they undergo intestinal epithelial metaplasia, and that's a need us for developing adenocarcinoma. So from there, they can develop gastric adenocarcinoma, and they can develop multi-lymphoma. So multi-lymphoma is just when you have um, malignant proliferation of the B cells within the lamina propria. So all the mucosa has three layers: the epithelia, the lamina propria, and the what's it called? The muscularis mucosae. So you have the muscularis mucosae, lamina propria, and the epithelium itself. So within the lamina propria, you have the um your lymphoid cells. So the B cells there can proliferate abnormally because of Helicobacter induced, malignant transformation. So they can develop mucosa-associated lymphoid tissue lymphoma. So H. pylori is also implicated in that. H. pylori is implicated in that. Okay. Um. Yeah. So what's the treatment option for Helicobacter pylori infection? You want to give the triple therapy. Triple therapy is just like ACP or APC, amoxicillin. You can replace amoxicillin with metronidazole in people that have penicillin allergy. The P is a PPI that can help suppress the acid. You know, then the C is the clarithromycin. So the clarithromycin and the amoxicillin will kill off the Helicobacter. The proton pump inhibition will help us, suppress the gastric acid the sorry that the um that the H. pylori is causing the stomach to release. Yeah, but there's another one that we call the bismuth-based quadruple therapy, particularly if somebody has macrolide resistance. So if there's resistance to clarithromycin, you just change the whole thing entirely. So you just give them the bismuth, you give them um, your metronidazole, you add tetracycline to it, then your PPI. So that's a quadruple based, therapy. Yeah. So let's move to the spirochete. Spirochete just means spiral shaped bacteria. Spiral shape. So these are what they look like, you know, microscopy. There are three: Leptospira, Treponema, and Borrelia. So you cannot visualize these guys on gram stain, particularly your Leptospira and Treponema. You can see Borrelia with light microscopy, and James stain. We talked about this when we were talking about those guys that you can see with James stain. Borrelia is what you can see with your James stain. So alongside with your Helicobacter pylori, your trypanosome, your Plasmodium, and all those things. So if you use your James stain or your writing, you can see Borrelia. Yeah, that's one way you can see through the use of the annealing dyes. But you have to see your treponema or your leptospira, you have to use some, particularly treponema, you have to do some advanced form of microscopy, like dark field microscopy. That's what you use. Yeah, it's already here. So treponema is visualized by dark field microscopy or using fluorescent antibody test. So there's something we call the fluorescent antibody absorption test. Yeah, so that you use to detect treponema is a form of serological test. It's not a um uh you know yeah, so it's serology. It's serology. So we are going to get there and we are going to shed more light on it. So there's what we call the Jarvis eczema reaction. So this is just consideration of fever, chills, headache, myalgia after you have used after you have used antibiotics to treat any of these spirochete infections. So if you give somebody that has Borrelia, Treponema, or Leptospira antibiotics, let's say penicillin for Treponema, and after like 2 days after they start developing the fever, the chills, headache, and myalgia, you know, due to the fact that there is damage to the organism and there's release of the bacterial antigen. So, that can cause the gyrocoptic reaction and that's that. So we should pay attention to gyrocoptic reaction. They ask it sometimes in those questions. So sudden onset of fever, chills, headache, myalgia, malaise after you have administered antibiotics to treat any of these spirochetes. That is your geric eczema, reaction. So it's not only confined to syphilis. So from treponema. So if someone has Borrelia infection like Lyme disease or leptospira infection, within the antibiotics, they can develop this eczema reaction. Okay, so Lyme disease. So Lyme disease, yeah,
Okay, but the treatment is still antibiotics, right?
yeah, the treatment is not about it, definitely.
How is going to resolve?
Yeah, it's going to resolve on its own. It's going to resolve. Yes. Okay. So Lyme disease is called by Borrelia burgdorferi. So the one we have, the one we talked about the other time, is one of those spirochetes, and it's transmitted by the exotic tick that you can get from there or from mouse. So exotic. This exotic is a vector for three organisms: Anaplasma, Babesia, and Borrelia. So Borrelia, Anaplasma, and Babesia. So Babesia can cause like something that looks like malaria. So Anaplasma, also can cause anaplasmosis, you know, and Borrelia can cause Lyme disease. So Borrelia, Anaplasma, Babesia. So BAB, BAB, Borrelia, Babesia, Anaplasma. All of them can be transmitted by this exotic. But we are looking at Borrelia for now. Um, it's common in the northeastern United States. Okay, if you guys want to pay attention to that, but some of us are like knowing some of those epidemiological stuff. But paying attention to the presentation is more important. So Lyme disease occurs in three stages: stage one, two, three. So stage one, that's early localized infection. So what's this early localized infection? Erythema migrans. So once this tick bites somebody, inoculate its saliva into that region, that saliva will contain this Borrelia burgdorferi. There's going to be an immune response to that burgdorferi. It doesn't produce any toxin. It's just the immune response to it. That's what causes that erythema migrans. So erythema migrans is just like a bullseye configuration. So you have double zone of erythematous appearance. So you can see this one in the center. I can see the surrounding one. It is pathognomonic of Lyme disease, but it's not always present. It's not there. I think in 80% of the time you see it. Yeah, so that's your early localized stage. The lesion at the site of inoculation of the infection. That's the early localized. Then with time, you have the early disseminated. So it's now getting into the blood. But it has affinity for some specific organs. The the cranial nerves, particularly cranial nerve 7, it causes cranial neuritis, but it likes the cranial nerve 7 more. We don't know why. So, but typically affect the cranial nerve 7 more. Then it also affect the heart, causes myocarditis. So they can present with um chest pain, you can have fever, tachycardia, you know, um uh dyspnea and all those because of the myocarditis. Then it can also cause problem with the electrical conduction system of the heart, causing AV block. So it can cause what type of AV block? Anybody? Lyme disease.
Third degree.
So we are looking out for third degree AV block with Lyme disease. So it causes myocarditis, causes AV block in the heart. Then it affects the joint and the muscles too, transiently. So both of them, they are transient, causes transient myalgia. So it can affect muscle or the lower limb now. Then tomorrow it goes to that of the upper limb. You know, it doesn't stay for a long time. So transient joint and muscle problem. Then the heart and the cranial nerve. That's it. So the heart for the early disseminated, the heart causing myocarditis and AV block, the cranial neuritis, particularly facial nerve, causing facial nerve palsy, Bell's palsy. So how will they present? They will have um thank you. They will have difficulty in smiling. They have difficulty in chewing. They can barely wrinkle their face and all those things. Bell's palsy. Then there is pain in the muscles as well as the joints. That's it. In stage 3, it's now associated with affectation of the large joint. So it affects the hip, the knee, or the temporomandibular joint. So they have this chronic arthritis. This late disseminated one actually happens after 6 months. So 6 months after the infection, they go to affect the large joints like the knee, the hip, and there's something we call this Lyme disease encephalopathy. So it typically affects cognitive function. So they are confused, they have memory issues, personality problems, you know, and peripheral neuropathy is also being observed. So we don't really know the reason why it specifically affects these guys in this stage, but it has been, you know, discovered that during that late disseminated state, that is the after 6 months after infection, you commonly observe this triad encephalopathy. You know, they are drowsy, they are confused, they hardly remember things, they have like memory problems, problem with judgment. Then there's pain, weakness affecting the joints, chronic arthritis, particularly the large joint. Then tingling, numbness in the nerves, peripheral neuropathy. So from the question, we should be able to nail the particular stage that we are looking at. So once we see the rash, that's early localized stage. Once we see that there's problem with the heart or a cranial nerve, not neuropathy, not peripheral neuropathy, a cranial nerve, we know that that is likely to be secondary lesion. So when there is like affectation of the CNS, like encephalopathy or peripheral neuropathy, that is a stage 3 problem. So what do we give? Doxycycline, that's the first line. So the commonly test this, you have to know doxy. Doxy is what we give. But people that are pregnant, you don't want to give them doxy. Why don't you want to give somebody that is pregnant doxy? Anybody? Or children?
Like recycling the discoloration.
Bone deposition.
Nice one, Dr. Good. Nice one, Dr. Rishola. So they cause what?
Discoloration
Abnormal
of teeth.
coloration of the teeth
Okay.
of the enamel.
Aside that,
Then the bone too.
the bones, the bones. So you are scared of the bones damage. What about um fluoroquinolones? What do they do?
Cartilage. Is it not the cartilage?
Cartilage. Nice one, Dr. Toby. So because of that, you want to give amoxicillin. So, but if it's very severe, particularly the disseminated one, and you have to give an IV medication, you give ceftriaxone. So the ceftriaxone will help you take care of um, the Lyme disease. So you guys remember that. Maybe early illness, not too severe, doxy. If the person is pregnant or person is very young, under the age of 8, you want to give amoxicillin. If it's very severe, disseminated, and you need to give IV drug, ceftriaxone can help you because ceftriaxone can penetrate the CNS and can treat, the encephalopathy and the other things that they come with. Okay. So leptospira. So leptospira interrogans. It's one of those parochets, those spiral-shaped organisms that we've, talked about now. And you typically get it from water that is contaminated with the animal body, particularly rats. So this guy is actually spread by rats. So it's very common in the tropics or people um that surf, all these surfers, you know, surfers like just do this surfing in the beach and all those things. They're exposed to a lot of water bodies of tropics, especially after a heavy rainfall. So there's flooding, there's a lot of um contamination, from all these rats because the water bodies will find a way and it will get contaminated with the rats urine, because of the flooding and all those things. So that's why it's common in the traffics. How will they present? So at the early time, they have this flu like syndrome. They just have fever, they just have malaria, they have headache, very non-classic stuff. Then with time, it migrate and affect the muscles of the calf. Classically, that's where it affects. This is what you are going to see. You guys understand what I'm saying? So once you see the calf myalgia, your mind is going to leptospira already. That's the way they are going to put it. Calf pain, you know what they are talking about. It affect the liver too, so they can have jaundice, affect the liver, jaundice, affect the muscles of the calf, myalgia. It causes inflammation of the meninges of the brain. So the flu-like symptoms, the myalgia, the jaundice, those are the um what do I call it now? The the leptoremic phase. That is the time that when it's confined to, the blood disseminating to all these tissues. There's an immune response stage. The immune response stage is when it now starts causing inflammation, you know, of the meninges of the brain. When the immune cells start responding to it, so they start causing, damage to some of the body part, particularly the meninges of the brain suffers that. So you guys might not pay attention to the face. Me, I just studied it with the face so that I can remember some of those symptoms. So I know that in the immune phase, that's when we start having inflammation of the meninges. So they can have some presentation that is very similar to someone that has meningitis. So they can have seizures, they can have neck stiffness, they can have photophobia. And one thing that is also classic about them is that they experience conjunctival suffusion alongside with the photophobia. That conjunctival suffusion is just meaning conjunctival inflammation. That is a conjunctivitis without exudate. So which condition do we have conjunctivitis with exudate that we talked about yesterday?
Neonatal gonorrhea.
Exactly.
Neonatal we shall
After ophthalmo or something. Myself, I don't
Ophthalmic or something.
The book of
ophthalmorum or something. Yeah.
ophthalmia neonatorum.
Neonatorium,
Ophthalmia
yeah.
neonatorum,
We
yeah.
dey figure anything that we go dey figure out am for workshop. We figure it out in the workshop. Yeah. So the
Abio.
ophthalmia neonatorum. Yeah.
Yeah, ophthalmia neonatorum. Thank you, Dr. Francis.
Yeah. So that's that. You guys remember, the calf pain, the liver affectation, then immune response phase cause meningitis, which is associated with photophobia and conjunctival suffusion. Now, that is leptospirosis. There's another disease that we now call well disease. Well disease is a severe form of leptospirosis. So, in this form, there's a predominant affectation of the liver and the kidneys. That is just what you need to know. It predominantly affects the kidneys and the liver. So, when it affects the liver, because they have jaundice. When it affects the kidney, you see features of exothermia, elevated urea, elevated creatinine. Now, if there is uh you know yeah, so that is, then it also causes damage to the endothelial cells, the blood vessels, which brings about hemorrhage. Yeah, I should not forget that. So there's affection of the liver, the kidneys with the blood vessels, which explains the hemorrhage that they present with. So it's hemorrhagic form. The affection of the kidneys, which causes the azotemia, and the jaundice from the liver. So the hemorrhage is going to bring about the anemia that they also experience. So the word is also known as the ecterohemorrhagic leptospirosis. So damage to the vessels, the liver, the kidney. So the kidneys can explain the AKI or the azotemia that they experience, the liver, the jaundice, then the hemorrhage causes the anemia. And of course, it's an infection, so there will be fever. So you want to be careful to look at the specific one that we are dealing with. Is it the ecterohemorrhagic one or normal leptospirosis? So normal leptospirosis, you might not see kidney dysfunction, you will not see hemorrhage and anemia. So you just see your, calf pain, your photophobia, something like looking at meningitis and your myalgia. You make your diagnosis straight up. So leptospira is what is causing them. Okay, so let's just round up with syphilis. Yeah, I don't know why I'm getting tired. I'm getting tired. So um, syphilis is caused by Treponema pallidum. The treatment of syphilis is penicillin G. Once you give penicillin, you are okay. Just like gonorrhea, ceftriaxone. All those bad diseases. They just have very simple treatment. It's not very. It's only HIV/AIDS now that is keeping people in check. So yeah, so syphilis has a cure, penicillin G, and Neisseria is what? Ceftriaxone. So three stage of syphilis: primary, secondary, tertiary. Primary syphilis is a localized disease that presents with a painless, non-itchy, well circumscribed, with irregular borders and a clean base ulcer that we call chancre. So once you see the question saying it's not purulent, it has well-defined edges, the base of the ulcer is clean, it is not painful, it is not itching, and it's found maybe in the vagina or the penis, that's likely to be primary syphilis. That's likely to be primary syphilis. The secondary one, it has progressed. So it's now affecting the skin, the mucous membrane, and the lymph nodes. In the secondary form of syphilis, there's affectation of the skin, the mucous membrane, and the lymph nodes. So they have some typical presentation like lymphadenopathy. Most of the time, that lymphadenopathy is kind of generalized, can affect from head to toe, up to down. Secondary syphilis. Then they can have this macropapular rash. They have this macropapular rash. So that's one of those skin manifestations. They have macropapular rash that can affect a lot of a very large portion of the body, particularly the trunk, the, the extremities. And one thing about this rash is that it affects the hands, the palm, and the sole. That statement is a very fantastic clincher. Once you hear it, I think there are three major organisms that cause rash affecting the palm and the sole. I forgot the third one now. Okay, I think
Hand, foot, and mouth.
yeah,
Hand, foot, and mouth.
hand, foot, and mouth,
Syphilis.
and
Um.
I think it's rickettsia. Yeah,
Okay. Okay.
yeah. So that hand, foot, and mouth, that's Kosaki. Which one? Is it A or B?
B.
Are you sure? It should be A. B is more of myocarditis.
I'm not sure.
Let us check. Let us
Let
check.
me check.
So that we'll not be moving stools for ourselves.
If I say the right word, pause.
Yeah. I used to
So no, we
that's the
pause.
problem with not having code. Even I say I have code now, I'll be sure of my answer, but I don't even know where it is. So
Yeah, you're almost there. I
It's
don't
A.
know. Is ARV?
where is it, sir? Okay, you guys have seen it, A and B. Okay, that's fine. So I think this is rickettsia. Yeah. Okay. It's yes. Okay, yeah. So it affect the palm and so there's rickettsia. So that one I think
Coxsackie A.
so
So it's Coxsackie A.
Coxsackie A, your Rocky Mountain spotted fever and sexual syphilis. So you guys can see the three here already.
Syphilis. Okay.
The three are here. But the rickettsia is a rickettsia. So when we get there, we are going to talk more about it. Yeah. So
And it's also a tick.
yes, it's a tick. Exactly, the tick. So you are looking out for the rash. That's the skin problem, the macropapular rash that affect the palm and the sole. Once they say that, syphilis should come to your mind. Then there's another lesion that you also observe in someone that's secondary syphilis. That's the condylomata lata. So those are smooth. They appear whitish most of the time. Do you have yeah? So this is it. Smooth, warty-like white lesions that you see in the body. You can see it in the anus. You can see it in the vagina. You can see it in the penis. You can see it anywhere. Condylomata latum. So this is not condylomata accuminatum. This is condylomata lata. So that is the wart-like lesion that you see in someone that has secondary syphilis. So that affects both the mucous membrane and the skin. So we're talking about the skin, which is predominantly the macropapular rash, then the lymph node. Once you mention those three things, you have said all the manifestation of secondary syphilis. That is all. But you can have a latent form. So, in some instances, it can just go latent. So all the symptoms will resolute. They will not be there. But the antibodies to the syphilis is still in the body. So the organism is still there, but it's just latent, it's just calm. If you do your serology, you detect the antibodies to the organism. but you won't see any symptoms. That's the latest form of syphilis. In some individuals, they can progress to have that tertiary syphilis. So this tertiary syphilis is a bad one, very destructive. So number one, syphilis is one of those infections that can also cause formation of granulomas. So once you form bumpy inflammatory lesions or granulomas in response to this syphilitic bacteria, you call them gomas. You can find gomas almost anywhere in the body. Gomas, they're everywhere. You know, once you are seeing it, they are describing like bumpy lesions or granuloma. You know that's likely to be goma. Then it typically affects three structures. Okay, the CNS, the the skin causing the goma. Then although that goma too can be found in internal organs. So okay, let me just say the gomas, the CNS affectation, and the CVS affectation. So gomas from the chronic granulomatous, lesion that you typically see in the skin, or you can also see it in the internal organs, the CVS manifestation, and the CNS. So let's take the CVS. So what it does to the CVS is just to damage the vasa vasorum. So vasa vasorum are vessels that supplies the large arteries, particularly the aorta. So once it's damaged to the vasa vasorum, it takes away blood supply to the outer two-thirds of the wall of the aorta, causing necrosis of the muscle, the medial of the aorta. So once that muscle necrosis happens, the next thing is for aneurysm to come in. So syphilitic aortitis is one of the causes of aortic aneurysm that can rupture and cause a stroke. We should not forget that. Very important stuff. So they can link syphilis to stroke, and everybody will just be confused. That's one way it can happen. So damage to the vasa nervorum, necrosis of the muscle, there's dilatation of the wall, causing aneurysm formation. The aneurysm can rupture and can lead to a stroke. So that's the CVS problem for tertiary syphilis, aside the goma. Then the third one is the neurosyphilis. Now, this neurosyphilis is like a spectrum. A lot of things they there. A lot of things full there. So it can cause the tabes dorsalis.
Sorry.
Yeah, Dr. Zlia.
Um, the part of the artery is it the what part? Is
The
the way we talk about it?
yeah,
What
so
part of the artery
the
is
media,
destroyed?
it can destroy the adventitia and the media.
Adventitia and the media, the two of them, Abi?
Yes. The outer two-third.
Okay, thank
Yes.
you. Okay.
So then the neurosyphilis. So one form of the neurosyphilis just went as affected the CNS. So tabes dorsalis. Who can remind us tabes dorsalis? Anybody? Do we remember from our neuro? What does it mean?
Posterior dorsal column.
Okay. There's affectation of the
Posterior
dorsal column, uh,
column.
the
And
dorsal
then
the dorsal root
yeah.
ganglion. So because of the affectation of the dorsal column, there is tabetic gait. So there's poor coordination. They are just staggering when they are moving. And you guys remember that dorsal root ganglion allows it participates in the deep tendon reflex. Your dorsal root
Mm-hmm.
ganglion is involved with your deep tendon reflex. So someone that
Mm-hmm.
has affectation of your dorsal root ganglion will have poor reflexes. So they can say the reflexes are absent. You know what they are talking about. All your nerves, all the fibers of our descending colon, your spinothalamic tract that are involved in temperature, pressure, and touch, they pass through the dorsal column too before they enter the spinal cord from the skin. You guys remember that they go through the dorsal, root ganglion. Now that means that this person will have poor sensation of touch. Then they can have neuropathy. So they have this because of the abnormality in the sensation of pain and temperature. So they can have what we call shooting pain or burning pain. So they will just be feeling pain, intermittently in a shooting manner because of the problem of those affectation of those um that ganglion that is conveying fibers from our spinothalamic tract. So they have abnormal pain sensation. They have shooting pain. So it can just get referred to maybe it's affecting the leg now, for example. So they affect a part of the leg now, they migrate to another part. So in a shooting manner. Sometimes it can just be burning sensation. So they can have ataxia, they can have poor reflexes, they can have What else again? You can have charcot joint from there. So because of the fact that your dorsal column are involved in proprioception, so they cannot find balance when they are walking. So that can cause micro trauma to the joint, to the um, joints that are dependent. Do you guys know what I mean by when I say the dependent joint, the weight bearing joint, the weight bearing joint?
Yeah.
So they suffer the micro trauma and they can lead to charcot joint. The charcot joint is like damage, you know, what's the word now? I don't want to use the word avulsion. It's like you are kind of cutting something gradually, and we don't have an image here. So that's just what it is. So charcot joint. Maybe you can check an image online. You can see the way it looks like. So that's one of the complications of tabes dorsalis. General paresis also occurs in people with tertiary syphilis. So we call this general paresis of the insane. General paresis of the insane. So these guys are paralyzed and they have some other problems too because it's more like diffuse affectation of the CNS. So they have some initially they can experience confusion, fever, headache, um, you know, dizziness. Then later it starts affecting the areas of controlling cognition. So poor memory, poor judgment, personality change. Then they start having some psychotic problems, delusion, they have hallucination, they are apathic, they are depressed, sometimes they can be manic, general problems affecting the CNS with paralysis. They can be bedridden. So from there, they can pass away from from there. People with tertiary syphilis also experience agiobatin pupil. So I know we know agiobatin pupil. So the when you try to shine light, the pupils will not constrict. Once you bring an object close to that pupil, they will constrict because the accommodation reflex is intact, but your pupillary light reflex is gone. So that one is actually linked to the problem with the Edgar-Westphal nucleus fibers. I don't know if you guys can remember that pathway from the brain when our optic nerve, comes around, they go. You guys know that the optic nerve actually travels from the front to the back. Do you guys remember that pathway? Or
Yeah.
should we just move? Maybe we should just move so that we'll not confuse guys. Because when we start now, we just hear and I don't want you guys to be doing So, but I don't think they will ask us the pathophysiology. But if you want to know it, it's actually due to problem with the dorsal nerves that are coming from the Edingar-Westphal nucleus. So, for the optic nerve goes to the back, they synapse with the protector nucleus in the midbrain. Then you have fibers that are moving from protector nucleus to the Edingar-Westphal that's just in front of it. The Edingar-Westphal now gives rise to different fibers, which moves as the oculomotor nerve 3. So those ones move forward like that. Then the synapse with the ciliary ganglion. Then ciliary ganglion now gives short ciliary nerve that supply the eye. Let me show us what I'm saying. So, what do we call this now? The optic. Let me see ending that Westphal nucleus. So, agirobatin pupil, we must not forget that stuff. It is specific for syphilis, tertiary syphilis. I think that is a very potent stuff. Like, it's just too important. Yeah, so this is it. But we will not be able to appreciate the pathology very well because this one is not very. See, uh let me see if I can get a better image. Hello, are you guys there? Or is my network that is bad? Hello? Hello?
Dr. Wale, we can hear you. I can.
Okay, so let's just move. Let's just move. Guys, just remember that it is the light reflex that is abnormal. Accommodation reflex is normal in them. A is normal. Agirobatin. A is normal. light is, defective. So what are the signs? They can have the broad-based ataxia because of the affectation of the tabes dorsalis, so they can have broad-based ataxia. They have Robert's sign, Romberg's sign positive. Charcot joint from the tabes dorsalis and stroke without hypotension. We explain this aneurysmal rupture. So do you guys remember what the Romberg sign means? Do we remember what it means? Romberg test. We are not talking, no.
Dr. Babani.
Hello?
Yeah, please can you repeat the question?
I said, do we remember what the Romberg test means?
Romberg is test of proprioception.
Okay. So how is it done?
You stand with both feet together.
You close your eyes and then you are walking, you are tandem walking, and then you close your eyes and then you see if the person will tilt to one side or not.
Okay. So if the person tilts to one side, what does that mean?
So that means you are trying to differentiate between a cerebellar and what's the other word?
Thank you.
Lesion.
That's what Dr. talking
So
So you are trying to differentiate between cerebellar and proprioception or vestibular. So
vestibular, yes.
yeah, three things helps you maintain balance: vision, your vestibular, and your proprioception through your dorsal column.
And your cerebral. Yeah.
Yeah, so those ones are the sensory. Those ones are the sensory modality, not the cerebellar. Cerebellar won't be like motor. Do you get it? So that's not sensory. Now, so what you do is that before you can have, maintenance of balance through the sensory system, you need to have two of those three functioning. Which are the three? Vision, vestibular, and the dorsal column. So you need to have two, at least two functioning. So you take one out. Of course, the person is seeing, so we already know that that one is intact. You tell the person to close the eye. Tell the person to stand, the legs together. Then, if the person has problem with either the vestibular or the dorsal column, the person will start, falling on one side. Do we get it? Someone that has a cerebellar problem, the person will not even pass the test of telling the person to be closing eye. The moment when you tell the person to even close eye, the person is already shaking. Before you close eye, he's already shaking because you cannot maintain balance at all without your cerebellar stuff. The person will start shaking when the person close eye, when the person has maybe your vestibular or um dorsal column. But even before closing eye, the person is already shaking. That's a cerebellar problem. Do you understand? Hello?
Well, please, no, I didn't quite get it well. So before the person even closes eye, the person would have started falling with a
Yes,
cerebellar lesion,
that's
right?
a cerebellar region. Exactly. So once you tell the person
So
to
if the person has their eyes closed, if the person has the eyes closed and the person is tilting cerebellar, but if the person can see and the person is still tilting, then something is wrong with the vestibular system. Is that it?
no, inverse, you have to change it. It's now the reverse. So, you know, if somebody has, I've said it that you need three things to achieve sensory balance. Three things: vestibular, vision, and proprioception. But two of them have to be working before you can achieve that stuff. You will need two of them to be working together. Do you understand?
Oh, okay. So is it that vision and cerebellar,
No, no, no.
vision and
Forget cerebellar for now. Forget
vestibular
cerebellar.
or
Cerebellar is not one of
vestibular? Forget
cerebellar.
cerebellar. Okay, okay, okay.
Cerebellar is not one of the sensory. Do you get it? Someone
Dr.
that has
Bali? Okay,
yeah,
okay, I can hear you now.
someone that has a cerebellar lesion doesn't have a sensory ataxia. No, no, that is not a sensory ataxia. The sensory one is your vision, your dorsal column, and the vestibular. You are using your senses.
Okay,
You are using your
okay,
senses.
okay,
You are using
okay,
your senses.
okay,
What are the senses?
okay. That makes
Your
sense.
ears, your
Sight,
eyes,
hearing,
exactly,
feeling.
your feet too.
Yeah,
Get
yeah.
it through the spinal cord. Exactly.
Mm,
That's it.
mm-hmm, mm-hmm.
So you need two of them to be working to be balanced. Now,
Makes sense. I think I get what you're saying now. So sensory ataxia will be if there is anything wrong with the senses, either your vision or
mhm,
your feel from your spinal cord, that's the dorsal column,
exactly.
or the vestibular tract.
Or the
Something can be
vestibular,
wrong with either of the three of them.
either of the three of them.
Okay, I think I get what you're saying
Now,
now.
you know
All
that for
right.
the person to see, so that means that you know that the eye is normal. So that one is intact. Right? So
Uh-huh.
you now tell the person to
Uh-huh.
close the eye. You tell the person to close the eye. That means that the person is left with two, which is what? The
Yes, either the dorsal column or the vestibular.
and we said that two of them need to be functioning before the person can be balanced. So it means that
Yeah.
once you tell the person to close the eye, and one of the other ones is problematic, the person starts shaking.
Oh, makes sense. Now I get it. Now I understand it.
That's what it is.
Okay, so
Can
you
you
see,
repeat the
so
last
once
statement?
there's
Sorry.
Dr.
The last
Luato.
well,
statement.
Oh yeah, Dr. Luato, tell
so
us
he
now.
said that. So he said that the sensory ataxia means the senses are not functioning, but for you to say the senses are functioning, at least two must be good. So you can know if somebody can see. If somebody can see, they will balance. So you now tell the person to close their eyes. You are now trying to see if the person's dorsal column or and the vestibular tract are working well. So if the person closes their eyes and they are now tilting to one side, that means something is wrong with either the spinal cord or the vestibular pathway.
Exactly. That is it.
Yeah, I get
But
it now.
but
So
someone
if
that
it's
has
cerebellum,
mhm,
if it's cerebellum, they
once you
will
tell the
not
person to start
once
working, even before the person close
they
eye,
will close their eyes, they will start tilting.
they will
Okay,
start
okay,
tilting.
okay,
Exactly.
okay.
So
But
that's
I'm sure you get it.
yeah, you got it now. That is it.
No, I mean Dr. Baba, Dr. Lushola, sorry.
Yes.
Okay.
Okay.
So let's
Thank you,
just talk
Dr.
about
Baba Wali.
yeah, you're welcome, Dr. Olatobi. So let's just talk about congenital syphilis and we'll go. So congenital syphilis is just some spectrum of abnormalities that happen to the baby in utero, due to transplacental transfer of this syphilis. So what are these abnormalities? What do they cause? So you are looking two things affect the teeth. Two things. Huntington teeth as well as um, Mulberry molars. So Mulberry molars and Huntington teeth. Huntington teeth means screwdriver or notch teeth. So you look at this teeth, it look like the tip of screwdriver or like this notch. You can see image G. Can we see this image G? Notched teeth, Huntington teeth.
Yeah.
So the molars also appear like the shape of a mulberry. Mulberry is a fruit in all those advanced countries. We don't have mulberry here. Now agbalumo we get. So so mulberry is it's a kind of
Lushola is coming for you.
is a kind of fruit and the molars assume the shape of those mulberry and we call them mulberry molars. So the incisors particularly is what become notched. So the
Dr.
incisors.
Bawale, sorry to say this. Just like I saw that that target cell thing,
Mhm.
where does it come from actually?
Come from as how? I don't know
Nah,
where it comes
you know,
from. Maybe bull
I,
eye.
I you know what I saw? I saw that there is a company here called Target, and their logo is the same thing as Target Cell. And now I was not putting together. I say, hope this thing didn't come from this rubbish
Okay.
company. Exactly.
Sometimes they get those names from those things, yeah. So incisors become notched or tin. The molars assume the shape of a mulberry molars. Yeah. So those are the two things that you find within the teeth. Then you go to the nose. The nose becomes like kind of the nose cartilage becomes destroyed kind of. So they have this saddle nose. It looks flattened. Saddle nose. Then they have snuffles. They're always having nasal discharge. Snuffles, saddle nose, those two things in the nose. Then you go to the mouth. So there's this linear shaped fissures at the angle of the mouth that we call the rhagides. I'm so sorry, guys. These names are very, very awkward, but I know that we'll get used to them. So you look at the teeth first, auditing teeth, mulberry molars. You go to the nose, notch or saddle nose rather, saddle nose, snuffles, then the angle of the mouth, rhagids, linear furrows or kind of indentation at the angle of the mouth. Then you go to the tibia. So the tibia is convex anteriorly. That's what we call the sabal chin. So you guys picture as if you are trying to bend someone's tibia bone. That kind of curve. Yeah. So the shin, the shin is the anterior aspect of the tibia. So they have the sabal shin, convex, you know, shin. And there's affectation of the cranial nerve 8, so they can have cranial nerve 8 deafness. Yeah, I think that's everything. So you have to treat someone that is pregnant very early because the transmission occurs in the first trimester. So if you are not quick with the penicillin G, the patient can develop congenital syphilis and affect the baby.
Baba Wale, are you pregnant?
Your
You're
your
yawning.
bed is in trouble.
Yeah, I just to be honest,
Bisola talk.
I just want to eat, and I'm going to be taking us pulmonology tomorrow. Now I've not even prepared anything about it now.
Why are you
So
taking us immunology? Questions?
yeah, questions. Yeah,
Oh, okay.
Yeah, let's stop.
yeah.
This
So
one, Dr. Baba Wale is already yawning, safe.
yeah, I'm very tired. I'm so tired.
Story.